And for our next section, we're going to have the rapid podium presentation. So each speaker will have 2 minutes to present their poster. So what I'll do is I'll introduce you all and you can come sit up here. So the first is Terence Carolyn, who's the Managing Director of CARF International, who's going to present on introducing field-driven interdisciplinary concussion rehab program accreditation standards. So Terence, welcome. And number 2 is Melissa Biscardi, who is a PhD candidate who is going to present on efficacy of restitutive interventions for oculomotor deficits in adults with concussions, mild traumatic brain injury, a systematic review and meta-analysis. Melissa? No, come on up. I'm going to have you all sit here so you can. Number 3 is Nicholas Moser, who's going to speak about effectiveness of personalized aerobic exercise program in adults suffering from persistent concussion symptoms. And so come on up, Nicholas. Great. Number 5 is Mac Hancock, who is going to talk about, who's a Bachelor of Science Neuroscience student. And he's going to talk about concussions and idiopathic normal pressure hydrocephalus. Is there a correlation? Mike. And number 6, Monica Shipinski, who's going to tell us about analyzing the effect of somatic mediators on post-concussion sleep quality in the general population, findings from the Toronto Concussion Study. So I'll have you guys all speak and then we'll take some questions. Thank you.
Great, thanks so much. Good morning. It's a real pleasure to be here. My name is Terence Carolyn, and I work with CARF International, a nonprofit independent accreditor of health and human services, as well as rehabilitation programs. And I'm really here today to share the effort that we've been engaged with the field of rehabilitation for over 2 years for the creation of interdisciplinary concussion rehab programs. Since 1966, we've been working with the field to use person-centered, field-driven standards. And over 18 months, we conducted 56 interviews with stakeholders from across the field of concussion, as well as the different fields of medicine involved in the delivery of this care, as well as individuals with lived experience of concussion, family members, and other stakeholders. Based on that feedback, there was consensus that the standards should be created and integrated into our standards manual and part of our accreditation. The standards were then drafted with a small multidisciplinary committee that used a modified Delphi process to draft standards. The standards were then shared with the public in a public field review. And there's no surprise, there was a robust response from the field regarding these standards, with over 200 responses that were integrated into the creation of these program accreditation standards. And I'll go back for a second and just show you again the sunrise on Cadillac Mountain in Acadia National Park. And as we look out into the future, I will tell you that the feedback that we received from the field is that there is enhanced access to care at the right time by the right provider. And that was feedback that we received from the individuals that we interviewed with lived experience of concussion, was that they struggled and languished to find the right provider at the right time. And it was their feedback and input that steered us in the direction of creating interdisciplinary standards. This is a summary of the standards as they exist now. They were published in January and available for accreditation in July. It is part of a continuous performance improvement process that makes up CARF accreditation. We are lucky to partner with organizations across Canada, North America, and across 5 continents. They focus on the individualized, coordinated, and return of persons served to life roles, including return to sport, return to school, and return to work. They require the prevention, treatment, assessment, and education of individuals and family members, coordination and integration of services. They also act as a resource to healthcare providers and community stakeholders. And they also look for opportunities to advocate for underserved and underdiagnosed populations. Education of persons served is required. Competency-based training, no-shows, cancellations, and dropout also need to be analyzed and data collected because people with concussions are very busy, and carving out 3 hours of the day for therapy and rehab is a big ask. These programs are rooted in evidence-based practice, and I appreciate all the work that all the researchers do in this audience because you provide the findings that help us deliver care out in the field with our accredited partners. That QR code at the bottom will take you directly to the concussion rehab program standards. I appreciate your attention, your interest, and your engagement. And for those of you who participated in the field review, thank you so much.
Good morning, everyone. As you know, concussions are complex. Almost 1/3 of Canadians will experience a concussion at some point in their life. And that is what has brought us all here today. Some of the most troubling symptoms experienced by individuals after concussion are those suggestive of oculomotor deficits. And despite its use in clinical practice, the utility of oculomotor rehabilitation is a source of feisty debate between clinicians and researchers. To explore this, we conducted a systematic review and meta-analysis. After researching 5 medical databases, screening over 7,000 titles and abstracts, we included 12 studies in our review. We found promising evidence. Participants had improvements in oculomotor metrics such as near point of convergence, reading rate, and symptoms suggesting convergence insufficiency. However, overall, studies had small sample sizes. There was a lack of control group. There was a lack of consideration of sex and gender, and there was variation in timing of the intervention as well as dose and frequency. So a much needed next step is a randomized control trial with a sufficiently powered randomized control trial that considers sex and gender and also timing of the intervention. In addition, future research can leverage novel technologies such as virtual reality and artificial intelligence in the assessment of oculomotor function and the delivery of the intervention. Needless to say, the future of research on oculomotor rehabilitation after concussion looks bright.
Spare. Thanks. Thank you very much. And it's a pleasure to be here to get the opportunity to talk about research that we're doing. This is a case series, which is part of a larger randomized clinical trial I'm currently conducting at Toronto Rehab. So what is this personalized care program? Well, every patient that comes into the office gets a standardized exam, and the standardized exam is inclusive of an exercise tolerance test. And this exam is done to help subgroup our patients to the ostensible etiology for the driver of their symptoms. And these 5 patients, the only thing that was wrong with them was exercise intolerance. So we prescribed a simple yet pretty specific exercise program. You can see below there. So for 30 minutes, 5 to 6 times per week, they exercise at 85 to 90% of their threshold. And that threshold was the level at which they failed the exercise tolerance test. In addition to this, we also had to meditate, more specifically doing breathwork training for 15 minutes every day. 2 of the 5 or 6 sessions of exercise was supervised by myself. And that's important because every week we retested that threshold to ensure we were properly advancing their intensity. 2 things I want to raise here. One is this case series, a lot of lengthy duration of symptoms, 3.5 months on average. And 2, every participant had at least 2.5 months of previous rehab, inclusive of exercise. Here we have every patient, the 5 patients, but just given the time here, I'll draw our eyes to the last column or last row. Quite symptomatic on the Rivermead post-concussion questionnaire, our primary outcome, 3 and 13 split into 2. The 3, for those not familiar, measures headaches, dizziness, and nausea. And the 13 is more of the psychosocial impact of their symptoms. So we can see they're quite symptomatic at baseline. PHQ-9 is a nice validated measurement of patients' perceived level of anxiety, depression. And we can see there on average, for those not familiar, they scored in the moderately to severe depressive category. And lastly, I put up the treadmill results because we can see in few of these, we often have to push patients a lot harder than we think. We'll jump now to our results. So again, I'll just draw our eyes, given the time here, to our last row, the average. Every single participant made a clinically meaningful change after just 6 weeks of exercise. Additionally, more importantly, almost, the change in their perceived level of depression and anxiety dropped all the way to a level of mild to no depression. For a little bit more time, I could try to get into why we think this is happening, but please come to me after at lunch. I'd love to have a talk with you if you're interested. We think it's because of this idea of exercise non-responders. And if exercise intensity is not sufficient for the individual, we won't see the necessary cardiovascular adaptations that we need in this population. Thank you for your time.
There's someone else's that was before one. Hi, everyone. My name is Matt Hancock, and I'm presenting on a study we completed called Concussions and Idiopathic Normal Pressure Hydrocephalus, and we're looking to see if there's a correlation between the two. So normal pressure hydrocephalus, or NPH, is a condition where there's a buildup of fluid in the brain's ventricles, and it can often lead to symptoms such as difficulty walking, inability for bladder control, and cognitive decline. And the idiopathic NPH is one where there is no identifiable cause or link to why these symptoms are starting. And our interest in studying this, in idiopathic NPH and its possible correlation with concussion, is due to some of the similar pathophysiological findings and symptoms, as well as the research showing that concussions has had a correlation with other neurodegenerative diseases. So to do this, we designed a case report form using a few already standardized TBI assessments, including the Ohio State University TBI-ID and the Brain Injury Screening Questionnaire from the Icahn School of Medicine. And we interviewed 3 different groups: the idiopathic NPH group, a Parkinson's disease group, and a healthy control group. And we interviewed them to determine their lifetime concussion history or traumatic brain injury history up to 5 years before their disease onset. So we looked at the mechanism of injury, the hospitalizations they reported, any loss of consciousness or total head injuries reported. And we did find that there was an increase in head injury in the idiopathic NPH group, and this was significant for the total number of head injuries between all the groups. And the idiopathic NPH group actually showed a more common occurrence of falling while walking as their main mechanism. So we also, to control for this, ran another analysis excluding more of the more common mechanisms, so loss of consciousness, hospitalizations, just as these might have been more related to their diagnosis. And following this, we still found a correlation with head injury and concussion in the idiopathic NPH group. So this is a study, the first of our knowledge of idiopathic NPH and concussion, and we did find a presence of more head injury and concussion in this group. Thank you.
Hi, everyone. My name is Monica Szczepinski, and I will be presenting on behalf of my team at Hull Ellis. Sleep changes following concussion are mediated by somatic symptoms. This is likely due to biomechanical cervicogenic injury, which impacts the brain's sleep-wake structures. And this diagram over here illustrates that vicious cycle that patients experience after a mild TBI. We hypothesized that early intervention for neck pain and headache may prevent the development of long-term sleep disturbance. The objective was to investigate the relationship between cervicogenic injury-related pain and sleep post-concussion at 8 weeks after injury. For our analysis, we included adults diagnosed with a concussion without prior sleep disorder or sleep medication use. And sleep was assessed by the Sleep and Concussion Questionnaire and symptom severity by the C.E.T.S assessment tool. Our results show that 220 participants completed the questionnaires at their week 8 appointment. Our sample included individuals who were on average 35 years of age, and 65% of those were female. The most common pre-existing disorders were anxiety, depression, and migraine. And this graph illustrates SCQ scores across 16 weeks. However, the point of our analysis was at the 8-week mark. And what we found at week 8 is that individuals with no neck pain had a much higher SCQ score, lower SCQ score than individuals with moderate to severe neck pain. And this was a 6-point difference, which was found to be statistically significant. In contrast, headache and overall pain were found to be positive, but weakly correlated with SCQ scores. So in conclusion, our findings suggest that we should target neck pain for assessment and treatment, specifically the use of cervicogenic therapy to mitigate neck injury in the early phases of recovery. Thank you all for listening.
Okay, well, we have a short break. Please come back at, was it 10:15? Yes, sure.
I just wanted to note that in the booklet, it says Melissa Biscardi, PhD, and I appreciate the vote of confidence, but it should say candidate, and just so nobody gets upset, I just wanted to clarify that.
All right, thank you. So please come back at 10:15.